Hello, thank you all for joining us today. Today, the title of our poster is a proposed program for increasing food security among drug and alcohol rehabilitation center clients. The background for our project is about 10.5% of American households are currently food insecure at one point in the year. So, some of the risk factors for being food insecure is households with children under the age of 6 years old, households with children where the head of the household is a single parent, women living alone or men living alone, and also heavy consumption of alcohol and illicit drugs. So, the population focus that this project focuses on is clients in a drug and alcohol rehabilitation center in Idaho. We chose this population because with drug and alcohol consumption, there is an increased needs and potential deficiencies among this population as they consume alcohol and drugs. And we also chose Idaho because about 1 in 8% Idahoans are currently food insecure.
So for program intervention, our proposed project consists of registered dietitian nutritionists visiting various rehabilitation centers in eastern Idaho to educate clients on government food assistance programs. We decided to structure our intervention around the health belief model framework. And in doing so, we coordinated each section under those 5 associated topics with the health belief model. So we have perceived susceptibility, perceived severity, perceived benefits and barriers, cues to action, and then self-efficacy. Under perceived susceptibility, we want to first make sure that the people that we're working with or the clients we're working with are even aware that a problem exists. This is kind of the health belief model framework that they're not inclined to change something if they don't know something is going on. So first, we're going to make sure to send out tailored surveys to drug and alcohol rehabilitation clients in regard to food security and assess overall how they feel their food security is and explore an overall desire to change after educating them on malnutrition risk and seeing if these people even have any sort of malnutrition. Perceived severity, we will discuss potential impacts on clients' health and educate them on consequences of malnutrition associated with low food security. Perceived benefits and barriers, we will explore the pros and cons of change, summarize and affirm the positive, and if at all possible, bring in role models and testimonials from successful people that have participated in the program before. Cues to action will involve how-to education, such as how to eat on a budget, how to utilize SNAP benefits, how to use WIC benefits to the utmost of your ability to provide nutritional sustainability throughout and provide more food security. We will also look to touch base with grocery programs and incentives for loyalty programs and things like that for clients, and then discuss available media information, follow-up surveys, and of course, connect them with SNAP and WIC programs. Finally, for self-efficacy, we will coach on alternative food choices, and then behavior contracting, which involves small incremental goals so they can be successful at their endeavors.
For program management, our staff will consist of 2 registered dietitians and 1 assistant. These will be full-time team members. The logistics is that the programs will be presented at rehabilitation centers as well as state health and welfare departments. Our resources is we will be providing SNAP handouts, which you can simply order online and ship to your home for free. We will be utilizing local grocery stores, maps, and stakeholders. So some of the stakeholders include program directors as well as grocery store managers to hopefully to develop more programs. Our market plan is to utilize social media, flyers, and emails. Our budget will consist of a total of $30,000 with $25,000 going for staff salary and $5,000 for travel expenses, handouts, and basically any other expenses that we may need. Our funding sources will be grant and collaborators. The program evaluation is we will send out post and pre surveys to determine the changes in food insecurity. And then the post surveys will be sent out 2 weeks after the seminars. For the timeline, we will spend the first 2 weeks doing office work, and then weeks 3 through 6 will be education weeks where we will go around to the different locations. And then the last 3 weeks will be data collection and data analysis.
For goals and objectives, our overall main goal is to increase awareness and utilization of government-assisted programs and services by decreasing food insecurity among drug and alcohol rehabilitation clients. The objective is to teach at least 75 clients amongst these 4 institutions that we'll be going to and increase food security among the population by at least 10%.